Cancer is one of the most terrifying and heart-wrenching diagnoses that a person can face. And in many cases, getting a diagnosis of cancer can feel like you're dying before you actually have. Now, imagine if someone offers you a treatment that doesn't necessarily shrink your tumors, but provides sort of relief from the emotional weight of living with this terminal illness. Well, that could be the promise of psychedelic therapy. And in Canada, something really big is happening. Queen's researchers have recently secured $5 million in funding to advance psychedelic research in cancer care at a national scale. And they'll be joining me today to chat a little bit about what they've got planned and what it all means for the future of psychedelics and cancer care in Canada. Hello and welcome back to the integration session. I'm your host, Dr. Elena Koning, and today we're going to be joined by two leaders making major moves in psychedelic research in Canada. Dr. Ron Shore and Dr. Harriet Richardson, who recently secured a massive grant from the Canadian Cancer Society and Brain Canada, are launching what they call CAN-PACT, which is a national collaborative that's aiming to transform mental health support in cancer care. The Center for Psychedelics Health and Research is very excited to be affiliated with this project, including our director, Dr. Claudio Suarez, who will be a co-investigator on the project. So I can't wait to learn more. Let's just dive right into it. Hello, Dr. Ron Shore and Dr. Harriet Richardson. Welcome to the integration session. You are both our first guests on the podcast and have some very exciting work going on. So really excited for this, and thank you so much for being here.
Thank you for having us.
Yes, thank you.
We can dive right in, but I just want to ask if you guys could introduce yourselves and maybe tell me a little bit about what led you to be interested in the potential of psychedelics in cancer care. So whoever wants to start.
I'm happy to start. Ron knows much more about the space than I do, but so he'll have much more to say. So, but briefly, I'm an epidemiologist in the Department of Public Health Sciences, and I work also with the Canadian Cancer Trials Group for the Supportive Care Committee. And maybe 6 years ago, we had identified a gap in our strategic priority around addressing mental health concerns in patients with advanced cancer. Actually, honestly, any patient diagnosed with a diagnosis of cancer may struggle and have some mental health issues dealing with that kind of a diagnosis. And so we decided to expand our focus and look towards complementary alternative medicine and other types of interventions, including medical cannabis and the psychedelics as potential areas of exploration. And momentum has grown since 2018 to today, where we got this amazing program grant that's going to allow us to do lots of things. I'm going to pass it over to Ron.
For sure. Yeah, no, it's an exciting project. I'm Ron Shore, so I'm assistant professor in the Department of Psychiatry here at Queen's University. I'm a research scientist, and I'm currently housed at a research institute called the Canadian Institute for Military and Veteran Health Research. So we predominantly look at physical and mental health needs of veterans in Canada and military serving personnel, as well as their families and public safety personnel. But my involvement in this trial came from my time in Queen's Health Sciences as a research scientist in our Psychedelics collaborative. So long story short, I did my PhD later in life and focused on psilocybin and its clinical applications. And as I completed my PhD, we developed a Psychedelics collaborative here at Queen's. We've now had a number of clinical trials completed. But in the early days, this was still quite new. So we built some capacity along the way. And the way I came to this was, I guess, in a number of levels. One, personally, my mother had a long cancer journey during my teenage years. So I grew up with a mother who was not only an amazing, lovely person, but was dealing with cancer, 4 or 5 different occurrences. So, we'd be bringing her to and from treatment and kind of watching her go through chemo. And she was so resilient and always doing so well. You always thought she'd make it through everything. But she passed when I was about 20. So that left a big mark on me, obviously, in terms of losing my mom young. But also, it kind of encouraged me to get a little more active in healthcare, in addressing unmet needs, particularly those of kind of psychosocial suffering. So I got involved in kind of drug-related health programs at an early age and started something called the Street Health Center here in Kingston. And that is a multi-service community health center looking at people with really significant addiction and mental health needs. And after doing that for many decades and teaching here at Queen's, I taught in health studies a course called Introduction to the Study of Drug and Alcohol Problems. My approach to teaching drug studies was always to start with the history and the botany and the biology of the plant. And so I taught psychedelics. I taught about psilocybin and ayahuasca for a long period of time. And then as Gabor Mate got kind of more interested in ayahuasca and psychedelic approach for addiction, it kind of caught my curiosity, and eventually I decided to do a PhD on psilocybin. So that kind of contributed to kind of where we're at now in terms of developing the field here in Canada. I think when I was doing my PhD, there weren't too many of us doing psychedelic research, and now it's really gratifying to see just the number of people doing, the quality of research happening at multiple Canadian universities. And so for me, CAN-PACT is just really symbolic of, really reaching a different stage of scientific research of psychedelics in Canada.
Mm-hmm. Great, thank you so much. Yeah, both amazing stories, and we'll get into CAN-PACT and the exciting work you guys are doing there. But first, I want to sort of set the scene for our listeners. So, whoever wants to start, what makes mental health support so important for people in cancer care?
Do you want me to start there? I actually,
What? Yeah.
you know what, I was thinking of that question, and I was thinking of, we have some amazing patient partners that are on our committee and are also on our program grant that we've just received. And I actually thought maybe a quote from one of them would maybe be a good start. So Hillary Horlock, who's this phenomenal, she's a breast cancer survivor. She's a patient representative on our committee for supportive care and also on this program grant. And she sort of wrote, so living with advanced cancer is emotionally draining and anxiety inducing for many patients, and that people living with advanced cancer can often experience things like depression, fears of death, and these growing anxieties on top of their many physical challenges, and that there are few supportive options available, and having an effective, well-supported treatment that is quick and long-lasting could be really important to both patients and the care circle. So I think really speaking to this idea that, you can go from living a normal life, you get up, you go to work, you're feeling maybe a bit tired, you go to the hospital, sort of get some tests done, and then you're faced with this suddenly a life-changing diagnosis that could potentially be life-threatening, and now you have to sort of circumvent a whole battery of tests and treatments, and try to manage your household and your physical care. And often I think your mental care sort of takes second place. And yet it can be really, catastrophic, right? Emotionally. And I don't think that the healthcare system has been well set up to properly address that facet of care. I think slowly we're coming to terms with that and recognizing that, but it's been a long time coming.
Mm-hmm.
Yeah, just to build on what Harriet's kind of laid out there is, I think our medical and health system does some things very well. And I think we deal with trauma very well. We deal with certain kind of interventions really well. Cancer treatment and therapy has come a long, long way. I think our family's fully cognizant. I think my mother had kind of been born 5 years later. She probably would have had access to treatments that probably would have kept her alive to today. So there's no doubt we've made advances on the biological side and the treatment side, due to, Canadian Cancer Society, all the hardworking cancer researchers. But I think, as Harriet indicated, what we often don't do very well is deal with the interiority of the experience and how it affects people's psychosocial functioning in the world. That's where the issue of demoralization kind of rises, is this mismatch between kind of what you'd hoped your life would look like and where you find yourself. There's elements of self-judgment that kind of come in there. But more and more, it's just, people have to suddenly come to terms with vulnerability, with medical frailty, or the thought of mortality, the thought of loss, the thought of change. And I think we have a society that's really focused on productivity and, kind of defining yourself in certain ways. And we don't do really well with suffering. We don't do really well with feeling sometimes. And so I think the whole experience of living with cancer, in terms of how it's affecting your worldview, how it's affecting your mood. We have limited tools. We have, antidepressant medications, which have limited levels of efficacy. A lot of cancer clinics are quite busy, obviously. We have social workers and people to help with the psychosocial side. But there's no doubt that the breadth of what people are dealing with, our interventional medicine has a harder time addressing. And that's where spiritual care workers, play a really significant role. And for me, psychedelics really start to raise this issue. Can they help us with understanding these internal worlds, whether we consider it consciousness or the emotional space people inhabit, if there's some element of spirituality that I think we know is related to health as well, that I think psychedelics can help us address. So there's no doubt the cancer experience, while we've done a lot to advance treatment, I think the psychosocial stuff is something we continue to try to address. There's been significant work around mindfulness in this and integrative oncology, where we're looking at alternative forms of medicine and bringing them in as well to help people with more than just the physical. Because cancer care is more than chemo or radiation therapy. It's the whole person we're trying to look at here.
Definitely, yeah. And would you say that mental health support for people with cancer care is very different than mental health support in like just general mental health? Like I imagine there's aspects of psychological distress associated with cancer that might be very different from other types of psychological distress. Would you say that's been your experience in research?
That's a good question. I guess it's the acuteness of it, maybe. Like it's, you're sort of, you might generally be this seemingly well-functioning person, mentally well-functioning, have a good sense of self and good quality of life. And then you're sort of hit with this potentially life-threatening diagnosis, and you're suddenly feeling a whole lot of emotions that maybe you're not used to feeling. And you might never have felt hopelessness before, and now it's sort of, it hits you. So maybe the acuteness of it is maybe a bit different, but I'm not an expert, so maybe Ron could sort of add to that.
Yeah, no, I think it's an interesting question, Elena. I mean, we're really looking at advanced cancer patients. So when you're looking at advanced cancer, you're looking at not only an escalation of the seriousness, it might be, stage 3 or stage 4, but also it may be multiple recurrences. And so people may have gone down a long road, if that makes sense. And I think for the most part, and I really appreciate the kind of survivor mentality where we've really encouraged this kind of like almost battle against cancer. We really praise cancer survivors. You see the placards around F cancer, and like I totally get it, but there's to some degree some almost like military metaphors that have come in, like the war on cancer. We're going to beat this. So what I have found is for people who are still struggling to kind of overcome, or they're not yet in remission, or again it's a new recurrence or a new metastases, people can feel like that's where the demoralization comes in, because even if you're doing everything right and you're attending all your appointments and you're trying to stay positive, there's just things we can't control. And the course of your cancer may be one of those. So it's a really deep vulnerability that brings up in people. And I think in our culture where we really prioritize wellness and think we can overcome everything, sometimes there's a little bit of a sense that, maybe I'm not doing things right, or there's something I've done wrong. Why am I not able to get over this? And, I've been a caregiver in a lot of situations, and in my family and extended family. And sometimes people, as they get really ill, there's just a sense of a disconnect between, why can't I just get better? I want to, I'm doing all the right things. And it's really hard for us to kind of come to terms with things we can't control. So is it different than other addiction and mental health? I think everything is circumstantial to the person, to their journey. We talk a lot about mental health, but really it's more of an emotional health, I think. So a sense of belonging really comes in here, and people's sense of identity really becomes affected. And if you're dealing with advanced cancer, you're then also looking at, are there things in life I'm going to miss or not be able to do? And as a society, and I'm going to quote Steve Jenkinson here, who's kind of Canada's kind of poet laureate, for lack of better words, on death and dying. He says we're grief illiterate and death phobic in this society. So we don't do a really good job helping people with understanding in everyday world, not just in the cancer space, but issues around mortality and the fact that we won't live forever, right? So you have that enter in. Meaning making is really key. I think a sense of purpose is really key for cancer survivors as well, because often the things we've relied on, whether it's the functioning of our body or being able to get up and go to work or think clearly, because chemo really can affect, your cognitive function. There's something called chemo brain. People kind of deal with a sense of feeling a little bit cloudy and not quite themselves. So you're always dealing with limitations. And to some degree, you don't know the outcome. So that uncertainty plus the demoralization, feeling like you're doing everything right and it's still not working out in the way you want, can make for something that looks very much like depression or anxiety in people dealing with advanced cancer. And whether that's same as depression in other circumstances, I think there's always variation, right? Circumstantial to the person and where they're at. Yeah. The other thing about cancer care is you're in touch with a lot of health professionals. You're in and out of appointments fairly regularly. You're in a lot of waiting rooms. You may be around other cancer survivors. So sometimes it's interactions with clinicians that may throw you off as well, because you're that, kind of involved in the medical care space, which, as we know, has its strengths, but also can be a challenge for people.
Yeah, definitely. And
I was going to say, just Ron mentioned earlier about sort of there's some social therapists that sort of are embedded in the health, circle, I guess the circle of care, but very few compared to the number of other healthcare professionals on a given team. So, we're doing another trial looking at an early looking at a psychosocial intervention in early palliative care, and trying to find enough social workers within the different clinical sites to participate is really challenging, because they might have one, for the whole oncology ward. And if that person goes on maternity leave, now we basically have to put that site on hold for recruiting patients until that person comes back. So that just sort of tells you how it's still, it's not a main focus, sort of, I think, in most of the oncology settings, having a strong presence of sort of social and other types of therapists present.
yeah,
And
yeah.
I don't think that's, even if you think about general psychiatry, Elena, like most, our standard tool is generally prescriptions, and we're looking at, psychiatric interventions that rely on adjusting molecules and all that. So even within psychiatry in general, we struggle to deal with the interiority of the person and their expectations and their motivations and all that. So I don't think it's just cancer care. I think it's something medical, the Western biomedical model in general, we've struggled to a little bit to address the spirit, the soul, the sense of meaning inside of people. Yeah.
Yeah.
Outside of the body or inside the body, however we want to define it.
Yeah, such good points. And yeah, so it seems like there's really a need for a more sort of comprehensive method or approach to help with mental health and cancer care. And I guess that's where psychedelic assisted cancer therapy comes in. So I would love for you to speak a little bit about, I'm going to combine a few of my questions here, but what is psychedelic assisted cancer therapy? What
Yeah.
is the evidence for its utility in cancer care, if that's even been looked at yet? And your thoughts on mechanism. So how is
Okay.
this exactly helping patients in cancer care?
Great questions. I'll go first, Terry. Does that sound good? And then you can fill in. Yeah. So it's super interesting for me, Elaine. I mean, these are really, really good questions. And as a psychedelic researcher, I've said a couple times when we're talking about CAN-PACT is I'm really, really pleased that the single largest kind of investment in psychedelic research is occurring within cancer care for a number of reasons. And one of those reasons is it's kind of where it began to some degree. Like you can kind of go back and where did psychedelics start, and we can go back into ancient history and traditional history, indigenous cultures, and that's certainly one track we need to understand the anthropology of these meaningful rituals using psychoactive plants for either social bonding or culturation, learning about cosmology. But traditionally they were used to heal. And they were used to heal physically and emotionally and spiritually as well. So in the Western model, we're not really used to talking about drugs to create an experience of mysticism or connectivity. So psychedelics introduces a bit of a new discourse into Western science and Western medicine. But some of the earliest research that I think has the best methodological rigor that has really helped set the stage for what you see today has occurred in cancer clinics, and that's using psilocybin to treat anxiety and depression among advanced cancer patients really over the last 25 years. There have been a number of studies, Charles Grob out of UCLA, Stephen Ross out of New York University. These were early studies. Roland Griffiths at Johns Hopkins in Baltimore. These are like 2011, 2016, maybe 2020. And those are really formative foundational studies that have then led to what we would call the psychedelic renaissance. Michael Pollan's famous book, How to Change Your Mind, which really blew the lid open on the popular interest in psychedelics, talks a little bit about some of those trials. And I think the trials in the cancer space, what they did is they turned to psilocybin because we know that in the scientific literature or the historical cultural literature that these could be experiences of meaning making, where people could have experiences that help them understand life after death, perhaps even, and that were commonly used to help people in transition as well into in palliative settings. So I think that the cancer care space was early on a good proving ground for psychedelic research. And what we found was the patients who were enrolled in these trials were reporting not only reductions in anxiety and depression and the metrics by which we study those, both self-report and clinicians observing, but also they were reporting them as being really significantly meaningful experiences, and often among the top 5 meaningful experiences of their life. Now, I don't want to give the impression that every psychedelic experience is that great, because sometimes they're not, and they can be extremely challenging. But they found in the early studies, even if it was a difficult experience for a person, they would tend to say that their psilocybin experience as part of their cancer journey became very meaningful because it helped them, I guess, unpack a little bit around sense of meaning, sense of purpose in life, often psilocybin, because it creates this time-limited period of altered kind of brain connectivity where perceptually and experientially you're feeling things differently, you're seeing things differently. The fact that you have a bit of an altered experience sometimes allows for new perspectives. We get set outside of the way that we perceive things day to day. And we know that within cancer care, often people can get quite ruminative, meaning that if we're struggling a little bit with the anxiety or the worry we have, we can tend to focus on that, and it becomes a bit of a repetitive loop. So that's called rumination. People might worry about, leaving their children behind, or they might worry about, are my affairs all in order? Am I ready to cope with everything I'm dealing? So it can become a little bit ruminative, and in that regard, their valence gets a little more negative. So the worldview changes to be a little negative. And we know within psilocybin, it really helps with your valence, in the sense that both during this session and after, people were reporting it has an antidepressant effect, largely because I think its effect on swelling and inflammation in the brain. So you have a really rapid reduction in inflammation. Psilocybin has a rapid antidepressant effect. So in the few days after, people were reporting feeling quite better. And then what was surprising for the researchers as they studied people over time is that those improvements seem to be persisting over time. And so some of the early trials would do follow-up at 3 months, 6 months, even up to 4 years, and found that people were still reporting improved quality of life. Some of the studies since then, and these studies have been repeated dozens of times now. I'd say there's dozens of trials currently in process right now. So what we will learn from the current psychedelic clinical trials, particularly around cancer, are going to far exceed the data we have from anything published to date, because there's so many going on now. But now you're looking at people even doing group psychotherapy as part of their psychedelic-assisted cancer therapy. Or there's one group in the States doing group psilocybin sessions. So we're getting more and more nuanced and specific to look at what variables are kind of affecting what, and what may be leading to the therapeutic outcomes. But the early trials gave us hope to think that there's at least some way that we can look at this demoralization syndrome that is kind of transdiagnostic and isn't necessarily a full diagnosis, but it's a syndrome, a cluster of symptoms people are dealing with that often include helplessness and hopelessness. And looking at the early trials, psilocybin and the therapies that come with it, and in our case we're choosing mindfulness practices, really can help people get over that rumination, can improve their valence, help them feel less depressed, and can really assist in what I would call meaning making, a sense of making sense of their life in its full context. There's often like a bit of an autobiographical review people go through within these experiences. So all of the early literature is quite promising. It's all obviously phase 2 and phase 3 clinical trials, so we're not quite at the point yet we have full regulatory drug approval, but the evidence is mounting. And I'd say the best trials, like the most methodological rigor, have occurred in the cancer space, as opposed to other areas in which you're seeing psychedelic research. So Harriet, feel free to build on that. Sorry to go on so long, but a big interest.
Yes, no, it's clearly a passion of yours. So my limited understanding to date is sort of, to Ron's point, there are these sort of neural networks that sort of talk to one another and maybe help support sort of, I guess, like Ron said, maybe rumination, or supporting if there's negative sort of negative dwelling, it sort of further supports that negative dwelling. And maybe something like psilocybin might help to disconnect those neural networks, maybe through certain receptors, right? But I guess some of the questions are, what is the extent to which the therapy that you have supporting that sort of a macro dose of psilocybin is important versus just the macro dose of psilocybin alone? And, some of these trials have looked at that. They've tried to sort of compare, a macro dose of psilocybin with assisted support, assisted therapy guiding you through your experience versus maybe somebody on an active placebo, but having sort of similar therapy and support. And in general, it seems that it's the combination of the macro dose of psilocybin with that assisted therapy above and beyond just that therapy alone. which is, I think, what's kind of really caught people's attention.
Yeah, so interesting. And I know it's a big question too. Like we know, or it seems like it's, a combination of the psychedelic and the psychotherapy, but then it's like the question of which psychotherapy, how specific, how structured. So how did you go about choosing what kind of psychotherapy model that you wanted to look at? I know you mentioned mindfulness.
Yeah, no, this is you can talk to this as well, Harriet, as well. But I think for me, you look at the different therapies, and even within the study of psychiatry and psychotherapy, it's a common understanding now that there's common factors that explain therapeutic success, and the model of psychotherapy people choose sometimes is secondary to the therapeutic rapport the person has. So there are different factors that we know that really explain the benefits of psychotherapy, and the style of psychotherapy is often one of the lower variables, if that makes sense, right? Sometimes it doesn't matter what you do. It's more like the fact you're doing and being present with people. You're an abiding, compassionate presence. You're creating a space for people to express vulnerability. And when you look at traditional psychedelic rituals, and for example, the Native American church, which does peyote ceremonies it's a pan-indigenous tradition, so multiple indigenous nations have embraced a peyote ceremony, but it's not only the use of a peyote from a healing perspective, both physical and spiritual, but it's a prayer ceremony, and people are disclosing and confessing and sharing and opening up, and everybody's praying with them. And really, this is an ancient rite that predates any form of psychotherapy, which is still a modern notion. Psychotherapy itself may be limited by the fact that it's dealing mostly with mental and emotional constructs, and we want to look at a biology mechanism too, right? Which I think is important. But when we look at the role of these psychotherapies with psilocybin, we know that psychedelics are really sensitive to a couple things. One is suggestibility, another is expectation. So we know that from a drug study perspective, it's not just you give someone these compounds and you get a predicted effect and it's the same for everybody. Within psychedelics, there's just tremendous variability. And these experiences tend to be really deeply meaningful and personal to people because they're so about them, if that makes sense. So as someone who's been able to work in some of these trials as a therapist and as an investigator, you just don't see two journeys that are the same. There's remarkable variability. So when it comes to what are you doing to prepare people and how are you integrating them after, we've evolved a model that's fairly standard now called PSI, which is preparation session integration, where we understand because psilocybin is so conditioned by what you do before and what you do after, that it's really important that the model takes on the whole thing. Everybody likes to talk about the trip, but the findings of my PhD research was the trip is fascinating and important, but what you do after is more important. Because if there is this plasticity, which seems to happen after, and improved global connectivity, people may be improved learners. They may be in a place where there's less neuroinflammation, there's better endocrine hormonal regulation, their body's working a little bit better. After psilocybin, you tend to have a little more sensory input, you're less in your mind, and it affects your kind of fear centers in your brain a little bit in the sense that it suppresses fear conditioning as well. So you're just the reset is a term we use, and it is kind of accurate to what may happen. So the question becomes like, what kinds of therapies can you combine with it? It was always thought that psychedelics were like non-specific amplifiers. So whatever therapy you brought in, the psychedelics could simply compound the benefits of that therapy. So you can use multiple therapies. What you want to do is find a therapy that has common principles, that we're looking at, basically psychedelics, because so much of it is an interior journey. People are finding their own meaning. The therapist's role is to support them. But in the psilocybin session itself, it's fairly non-interventional. You're there for safety, for encouragement, for a little bit of dialogue, make sure things are going well, deal with the music, tend to people. You're abiding, you're just kind of a calm, abiding presence, but you're tending to people as well. So that's important just from a human relation connectivity. You build trust with people. They trust you enough to go into a deep space together. And then afterwards, there's just a feeling of accomplishment because people have done something hard, something that can be quite mind-blowing, quite literally. So it opens you up. A lot can come up, a lot can come out. So what you want are therapies that really support people and resonate for people. So, for example, in the alcohol use trial we had here, we combined motivational enhancement therapy, which works really well with addictions. The choice of mindfulness, I think, was perfect for this trial for a number of different reasons. One is we know mindfulness and psilocybin have very similar common mechanisms in terms of how they affect the brain. And early literature looking at combining the two, whether it's in a retreat setting or in kind of naturalistic settings or in clinical trials, mindfulness seems to increase the gains of psilocybin. It seems quite consistent. So it has face validity to me, and at predictive validity, it seemed to have similar outcomes. And I really like it as well because it is a bit of a safe space. Mindfulness is almost like a secular meeting place for various practices. You can even have a spiritual element in it. One of the problems with doing kind of this kind of research with people in our culture is we don't often have common language around spirituality or experiences that may be non-ordinary, and people have different cultural beliefs. So you want to respect the different religious and cultural beliefs people may have. Mindfulness is a set of practices that are focused on non-attachment. And one of the things about psychedelics is it teaches you very clearly in the moment you can't attach to things because you're not really able to keep up or be in control, and then you kind of have to let go. And it's the letting go for people that can often be can be quite therapeutic. Is that ability to kind of just trust the process, because you can't mentally keep your same narrow view of reality when the psychedelics come on. They just, so much new information, so much novelty is coming up. The way that your brain really limits sensory stimulation and builds a coherent model that you can predict reality, all of the blood flow to those brain regions really reduces. The serotonergic agonism means that there's a shift in global connectivity. So people are experiencing reality much more from the bottom up and less predictive. So that can create difficulty for people. And the leading adverse experience is transient anxiety and distress, which is understandable. The psilocybin accelerates heart rate a bit and blood pressure early on. People get a little interoceptive, they notice it, and then that can accelerate into anxiety if people don't know, that's transient and common, it's going to pass. It's part of the stage of the journey. But when you get through that, things can really open up for people. And you just want forms of therapy that when they come out with this experience that will be primarily around meaning making, letting go of things, there's a lot of forgiveness, a lot of autobiographical review, cognitive flexibility that comes up, taking different perspectives. People can feel very forgiving. And even just biologically, after people are a little more connected to their environment. And Robin Carhart-Harris, who's probably the leading scientist on psychedelics, talks a lot about, has a few really good catchphrases. One is psychedelics break chunks into bits. So these habits and views of the world that we've become stuck with and formed over time or hurt and experience, it allows us to break those up and change them a little bit. And I think that's a really helpful construct. But he's also really clear that what psychedelics do is they reconnect you to context. And this is what serotonin is really largely tied to your environment as well. So it seems to be that psychedelics reconnect people, or can, to their relationships. People feel and report feeling more connected with nature afterwards. They feel more embodied afterwards, more connected to people in their life. Maybe that's letting go of some of the blame or judgment or guilt we carry, frees up added connectivity, which you can imagine for someone dealing with advanced cancer. Then feeling closer to the people in your life and more resourced by nature and better connected to nature, you can really see how the people could feel. That's quite beneficial. So mindfulness, because it's based on non-attachment, works really well with this, because you're not attaching to the thoughts and emotions that you're experiencing in this. And we want to kind of get away from over-attaching with our negative symptomology when it comes to like this worry that we get. So for me, it's a perfect kind of blend, and it's a secular meeting place for a lot of different therapies can come in, and you can even have a spiritual experience within that framework.
Yeah. Yeah, it's such a interesting kind of treatment. Like psychedelic therapies just always amaze me how like adaptive and flexible they are, and that's part of why it could be so fruitful in the future. So moving on
Yeah.
to the initiative that you guys are working on, obviously I want to extend a major congratulations on your successful grant from the Canadian Cancer Society and Brain Canada. It's a huge accomplishment and so well deserved. So can you guys walk us through the vision for CAN-PACT and what the initiative is all about and what you think it'll help do that wasn't possible before?
So maybe I'll start and then
Yeah.
let Ron sort of, yeah. So I mean, I think there aren't a lot of opportunities like this. So this was a major breakthrough program grant. So typically, we should also say, so Linda Carlson, who is the other PI on this project program, is based in University of Calgary, and she works closely with. I've worked closely with her on other trials around mindfulness, for example. She's really an leading expert in that space. And we had put together a CHR grant looking at psilocybin-assisted therapy in a phase 3 trial space. And we had some support from CIHR, but clearly not enough funding to sort of launch that trial sort of as is. And but typically we would have to go back to CIHR and try to get another project grant to try to get sufficient funding to get that trial up and running. So once in a while you get one of these program breakthrough grants, which allows you to really build a team and not just work on one clinical trial, but potentially develop a few studies within the program. And so with this program grant through CCS, we're going to build a sort of a network of patients and healthcare providers and clinicians and policymakers and everyone who wants to engage in this space to help really move the dial forward in seeing psychedelics potentially be available and accessible, sort of in an equitable way, in 5 or 10 years from now for Canadians who might need this kind of support. We're going to sort of do it in a stepwise fashion. So first, we're sort of finding out everybody out there who is who is interested in psychedelic research, and create a network. We're then going to be we've got various subcommittees overseeing aspects of the program. Another big piece that Ron's going to talk about is just education and capacity building. So how do you build the next generation or a generation of therapists in Canada who can deliver psychedelic assisted therapy in the future. And we want to have students and trainees sort of at ground level with us, working with us, and also being able to lead the way in the future. And then we're going to be working on developing a pilot study. So based on some of this engagement and priority setting, it's going to help inform what a pilot study is going to look like, that we're probably going to start at Queen's in Calgary. And that will probably inform then a larger phase 3 definitive trial. And we chose demoralization or existential distress or suffering because some of the earlier trials that Ron alluded to, particularly conducted down in the States, typically looked with advanced cancer patients, they looked at depression and or anxiety as sort of as primary endpoints. And demoralization was often an important secondary endpoint, and there was often a signal in those trials, but it was never, these trials were never designed to study demoralization as a primary endpoint. And we thought that this was really in the advanced cancer setting, probably one of the more, potentially the most important primary endpoint. And so there's a lot of work that we need to do also to figure out how we're going to screen for demoralization. This is not, there are fairly well-validated screening tools to assess if a patient might be, suffering from depression or high anxiety. There are less well-validated demoralization scales that are used in typical practice. Certainly, there's not like a one-question item, right, that can get at that. So these are some of the things that we're also going to be developing or fine-tuning so that when we do launch our clinical trials sort of in year 2 to year 4, I guess, we'll sort of have, the best measurements available, and we'll have a better sense of what our comparator is going to look like, and be informed and have constant ongoing discussions, again, also with policymakers. What kind of evidence do they need to make changes, make real changes, for in our healthcare landscape, in Canada, a decade from now, for example.
Mm-hmm.
Ron, do you want to add to that?
Yeah, I just want to, it's the thing I always say about this, which is the fact that it's 5 years, Elena, and not just what I would call a one and done clinical trial is a huge difference. So, and not to take away, we have a number of really good clinical trial activities here at Queen's in psychedelics, as you know, that are kind of standalone clinical trials and on a variety of molecules, and you learn something from all of them. But when you can group trials together into a coordinated framework, and you can have the time to build capacity and build in knowledge translation and mobilization from the get-go and involve stakeholders, patients, but also policymakers from the get-go, you just have such a better integration of science and program and science and policy, science and practice, because everyone's at the same table from the beginning to the end. So having 5 years is awesome. a huge part of that, as Harriet indicated, is developing capacity. So we're developing our own education and training for a number of different streams. One is the clinicians. The others are going to be, public members, people in policy, but also the patient population, and for our research trainees. So what this is going to do is just accelerate the scientific infrastructure around psychedelic research, because you're going to have, hopefully by the end of this, dozens of trainees who've then kind of grown up, I mean academically, scientifically, with all of this training, whereas we're creating it, or in my generation, we've had to create it as we go. So we really hope it's a legacy piece. There's really no evidence-based gold standard model of education for therapists doing psilocybin right now. There's various universities and institutes doing training right now. So we want something that has a little bit more of a consensus, a little more basis in evidence. That's going to take some time to develop. But part of what we're doing is what's called the James Lind Alliance priority setting, which is a very inclusive process to help develop your research kind of program. So that will help inform the education and training that kind of come in and out of that. But I think the 5 years is just super critical, because we can build capacity. The greatest thing about psychedelics, I think, is it brings in people from multiple disciplines, and it has a transdiagnostic application. So what we do here should benefit other areas of research, whether it's addiction treatment or depression. I'm very interested in demoralization for a number of reasons. One is being very active in the veteran health space. We know demoralization is common for military veterans as they leave service into civilian life and life after service. It really affects mental health. We know demoralization is common across other medical ailments as well. And I think personally, and I think there's some literature to support this, that it's a precursor to PTSD. So if we can deal with demoralization after traumatic exposure, or demoralization as it develops, we can perhaps minimize, mitigate, offset the more problematic severe sequela of full-blown PTSD. So I think that what we find in this trial, there's going to be a number of adjacent spaces that will really benefit, not just from more people trained in the proper methods and methodology, which psychedelics really needs. I just want to say that, like, part of the hype around psychedelics and the pressure to kind of get these to people, accelerate regulatory channels, it's meant that to some degree safety hasn't really been addressed as well as it should be. There's been a bit of this expectancy hype, or a social contagion, a belief structure around psychedelics is it's the new psychiatry, it's going to save everyone, and obviously, never trust there's no such thing as a magic bullet, everything in its place and for the right time at the right person. But we'll be able to better identify what kind of candidates do well with psychedelics and what don't through measures like this. And I just think the investment in the research infrastructure is going to pay dividends. I think Harriet and I both feel the same way. Like, it's our students that are going to make even more change than we've been able to make. And scholars like yourself, Elaine, as you move into, you're going to be able to do so much more because you're standing on the infrastructure everyone's built over the years. And I think the infrastructure left behind in this will be significant and lasting. It'll be a legacy from this whole project. I think it'll change cancer care. And it's done so thoughtfully that it's not we're just doing it and then telling other people they should do it. It's like you're bringing everybody in. And it's a very inclusive space, and we're trying to solve these kind of implementation issues along the way, and even like the idea of doing a group session with people with psilocybin. We wouldn't have talked to that many years ago, but as we're getting closer to trying to treat more people, cost effectiveness is a real issue. Can you, instead of having 2 sessions where you have 2 therapists and probably a psychiatrist or a physician on call with someone for sessions, can you do 8 people at the same time? And I'm not trying to take away from quality, because I think even the literature would show there's benefits to doing these kinds of interventions and having these kinds of experiences in group. In part, it helps people overcome this notion that they're alone. They can bond with other people. It can help them feel reinvigorated, more moralized. And it's funny for me. I mean, I got interested in psilocybin because when the literature was showing like it had transdiagnostic effect, it seemed to help people with addiction, with depression, with demoralization, with, now it's being, obviously eating disorders is an area of interest. And now we're looking at more neurological, Parkinson's and Alzheimer's. So for me, the transdiagnostic potential was always super intriguing. And then as we looked more at demoralization, this is Jerome Frank, who was a psychiatrist from the States, who wrote a book on psychotherapy, and I think around 74, if I'm not mistaken, Harriet. He kind of coined this term, demoralization, and he thought it was at the essence of every reason someone would ever go see a psychotherapist. What the psychotherapist is always treating is demoralization, whether it appears as addiction or eating disorders or depression. Your role is to help remoralize people. So again, you now have this transdiagnostic approach which was my whole interest in psilocybin to begin with. So I think we're getting at something that's at the root of a number of different ailments and can be of benefit in a number of different kind of sectors, I think, in healthcare.
Yeah, so exciting. And I agree with what you said about building this sort of national network and really focusing on clinician training and policy. It's so important than just doing sort of like one trial. I think it'll help make lasting impacts, which you've also alluded to. Looking ahead, like 5 or 10 years, if everything goes to plan, what do you think that cancer care will look like in Canada thanks to CAN-PACT?
I'll let Harriet go first on this. She's had a longer time in the cancer space than I have.
Well, it's interesting because I think, particularly for something like psychedelics, like psilocybin, which is a controlled, sort of regulated, I guess, under the Controlled Substance and Drug Act. If I think about other clinical trials where we're looking at maybe a first in man, first in human indication, there's a number of thresholds that have to be met before the FDA or Health Canada will approve it. And then there's discussions about whether it's going to go on the formulary, whether the provinces are going to fund it, right, for it to sort of enter the actual, say, clinical care and be added to the list of approved drugs for treating a particular condition. I think for something like psilocybin or in the psychedelics, it's a more complicated series of steps because it's really around how do we change the regulations around access to psilocybin, or should it prove successful? Should it prove efficacious in the trials that we're going to be running? And if the collection of data, not just our trials, but the data that is generated over the next 5 years continues to support a role for something like psilocybin, I think it's going to require potential just a change in how it's regulated and how clinicians can access it. Right now, it's on a case-by-case basis, and you have to sort of apply for special access to be able to give it to your patient. Patients have to sort of fill out a whole lot of paperwork. It's really cumbersome and often, just doesn't end up happening. And particularly at end of life when there's a short time sometimes, right? You want to get this treatment to patients quickly. They don't have the time to go through all the paperwork and the bureaucracy. So I would like to say that, I mean, 5 years might be too short, but that's definitely within the next 10 years that regulations will have changed so that we have a different sort of system whereby we're not adjudicating, we're not getting access to psilocybin through this sort of case-by-case special access program, and that it's sort of more, there's a sort of more general access to it through clinicians will have more of a general access to it and have discretion at how they're going to be using it. Ron, you've worked a lot with David Clemens, who's done a lot of thinking about this as well. So maybe you can follow up on that.
Yeah, no, for sure. I'm really glad you started with the regulatory stuff. I think even, I probably started my PhD almost 10 years ago, and during that time we've seen shifts. For example, at that point, you couldn't even get special access to psilocybin, LSD, or MDMA because it wasn't a part of the CDSA, which is our overarching drug legislation that made you couldn't even access it for scientific or humanitarian grounds. That has shifted, and Health Canada has been proactive about making it available by exception for people for humanitarian or compassionate reasons, although granting approval by exception isn't a policy. It's like it's a weak moment for now that allows things to kind of happen, and by no means are we seeing this as a long-term solution. It's odd. It's bureaucratically very cumbersome, but it has also opened up the potential for more science in this area, and that's why we're seeing so many trials now across Canada. I don't know the number of currently active psychedelic clinical trials in Canada, but it would easily be dozens, if not dozens and dozens. So it's impressive, and the regulatory changes have allowed that. My understanding in terms of potential future regulatory changes, whether we're talking about decriminalization, legalization, improved access, prescription, that the regulators, and in this case we're looking at Health Canada, is looking at safety and wants a strong and robust enough scientific program of research that isn't just quick, here's our results, but builds over time. And that's the other nice thing about CAN-PACT, Elena. These are major Canadian institutions. We got 5 university sites for the trial itself. We have, I don't know how many universities involved formally now in our network, but it's very much university-based for a reason, to help develop that objective, arm's length, scientifically valid information that they're waiting on, that's not coming from an interest group or a private group. and really has compelling safety data and captures, we need to improve methodology in psychedelic trials, and we have been doing this. This is an opportunity to do it even better. So the regulators through this trial will have access to way more information, including safety. The sheer number of people we'll be treating at some point is going to give us a lot more data. And I think it'll have a lasting impression in terms of the regulatory changes that may be made possible from this, but that's not the main reason we're doing it. It will reshape cancer care. I think in part, I've always liked the term integrative oncology. This is something that Linda Carlson talks a lot about. And I really like the term. And for me, as a guy who studied a lot of psilocybin, I always come back to this notion of doctrine of signatures. And I don't know if the listeners will be familiar, but this is a very old, almost like folkloric model of how to understand the medicinal value of plants or roots or shrubs that you come across in the kind of more traditional societies. And the idea was that the biological function of the plant and the way it appeared would indicate something about its potential therapeutic use for humans. So say, for example, if a plant was red, it might help with blood disorders, whatever. But with psilocybin, the doctrine of signatures is, for me, if you look at the way mushrooms work, and we all know this vast underground mycelial network is quite fascinating. A mushroom is just a fruiting body that pops up and is very temporary, and it comes from this vast underground network, which is a network which shares nutrition, shares information, shares resources across species, between trees, plants, grasses, shrubs, mushrooms. It all gets integrated, and it becomes almost a neural network. So we know that psilocybin, these are connectors, these are integrators. So I think the lasting effect of this will be to help integrate cancer care better, to understand the interiority of the cancer patient, the interior world. They're the mushroom that pops up from this underground network. But what we're all connected by is this notion of our environment, our relationship to each other. The global connectivity that happens in the brain as part of mushrooms is also kind of consistent with this. It integrates the parts of yourself instead of getting more caught up in just your mind and worrying and this ego basis. Psilocybin can help us with more global integration of our neural networks, so you're a little more embodied, you're a little more in the moment. You're getting more sensory and somatic awareness. You're tied into your memories better. You're not just operating on anxiety. So that simplification, when we ruminate and our brains really do become, parts of them become overactive, it helps integrate all that. Just like in healthcare, this will help integrate. I think it's very transdisciplinary. You can't do psychedelics without involving your death doulas, your social workers, your psychiatrists, your oncologists, the primary care, the nurses. I think nurses are going to play a really important role we haven't really talked about. And to me, that's almost like the best outcome is it gets everybody together, because that's just the transdisciplinary nature of psychedelics. You have all these different perspectives that are required. So it's called the Canadian Network for Psychedelic Assisted Cancer Therapy, because our thought is over time this will become more mainstream as a possibility. It's not going to be there. It's not going to be perfect for everybody. And for a lot of people, it may not be necessary or even helpful for some people. But at the same time, it'll be another tool in the belt. And I think most importantly, it recognizes people's interior world, their fears, their expectations, their concerns around mortality. And it allows us better tools to start addressing and talking about those very difficult things, including death and dying.
Yeah.
And maybe sort of, if you think about cancer centers right now, the way they're set up, there are a lot of centers now have rehabilitation sort of centers, and even there are opportunities to maybe engage in exercise and physical activity and other. Yeah. So there's a number, a nutritionist to help with nutrition. So in the future, it'd be nice to sort of see an expanded space also for this type of well-being, right? So a place for to be cared for the mind to be cared for, and safe spaces, safe rooms to maybe undergo PAT or other types of therapeutic experiences.
Yeah. Mm-hmm. They're very tender experiences. Psilocybin, everyone talks about how they can be like altered states, and the visions and the visuals often get a lot of attention. But I think the thing that has struck me the most, Elena, is just what a tender space it is, and that's why it's so important you have really skilled therapists who have built time, safety, and rapport, because people really do open up and they let go of a lot of fear, and they kind of walk into things that normally were too overwhelmed or busy to really deal with. So there's this tenderness and this sweetness that comes out, and I think we can all do with a little bit more of that in this world.
Yeah. And as we know, with the aging population, we're only going to see more and more diagnoses of cancer, and so really hoping that our provincial and federal governments will sort of invest in mental health support and therapists sort of right, to support these cancer clinics and our patients through their journey.
Yeah, well said.
Yeah. Yeah, thank you guys so much for walking us through your initiative. Truly, it's super exciting and I think has the potential to really transform cancer care, like you mentioned. So thank you and congratulations again on that. And I think this is fitting to lead into sort of my last question for you today, which is, I named the podcast the integration session because I think there's a lot we can learn from psychedelics that could make a meaningful impact on just everyday life. So what is something that you think that we can learn from psychedelics, maybe through like personal experience or even just the act of studying these substances that you think makes a meaningful impact on everyday life?
For,
You go first, Harriet.
okay, you'll. For me, I think it's just an openness, right, and being open-minded to like maybe some former stereotypes about these types of experiences and psychedelics and it being just a fun recreational drug, and or not, depending on your experience, if you've ever sort of played with it. But I think being open-minded about well, first just being really understanding of what what mental health looks like and the potential role that being open-minded about new forms of managing and supporting distress. And I think at moment if I think about me personally, I probably in an earlier phase of my life being somewhat skeptical about psychedelics and this type of therapeutic approach. But I've sort of really I'm at an age where I've got family members and or good friends, having sort of shocking, devastating, diagnoses around cancer or other terminal illnesses, and really hopeful that this type of intervention can really bring some peace, right, to people struggling with this type of diagnosis, and to the caregivers even. We didn't even talk about caregivers and the role that maybe, right, this type of therapy might have for people who are witnessing their loved ones go through the agony of end of life. Yeah. Sorry, I brought it back to sort of end of life and cancer, but Ron, what do you have to say?
Well, I like your focus on peace. I think for me, Elena, I've always tried to synthesize the two separate streams of there's this huge Western biomedical interest in psychedelics. And then, from more of my drug studies background, I understand more the importance of the culture and the history and indigenous ritual. And I've been fortunate to be included in some of those rituals, including a Native American church peyote ceremony. And it's stunning for me, just the impact of these on culture and how they can help people in terms of getting a sense of their place in the world, but also really bond. It really brings people together. There's something about ritual we've lost in our world, people coming together in meaningful spaces. So it helps reinvigorate that. But historically, these kind of visionary plants or magical fungi were always seen as visionary experiences, like they're paths of learning, in shamanic societies. And I think in this case, it's no different. And often we struggle, does this fit into Western culture? But if you go back to the origins of Western culture in ancient Greece, the Oracle of Delphi had inscribed on it, know thyself, right? It's the essence of Platonic and Aristotelian philosophy is self-knowledge. And I think the thing about psychedelics for me that I think has been clear for a long time is they can help reveal to you the workings of your own mind, which is the origin of the term psychedelic, which is mind, and better, soul. Better than mind is soul manifesting. Because we think of mind as just thinking, but the ancient Greeks, it would have been more your whole interior world. So it helps us because you go through these experiences that just show you something about yourself, that shows you your perspective. It shows you the limits of your perspective, and it can show you alternative ways of thinking simply because of the biological changes happening in your brain. So they have centuries, if not eons, of history of being medicinal. We know that they can have value to people, both physically and therapeutically. Bringing that into Western culture, as Harriet kind of indicated some time ago, people would be a little bit more suspicious. But I think we're kind of advancing to understanding a little bit more about our relationship with the world, about reconnecting with some of the kind of notion of these rituals and the importance of just allowing our internal world to be recognized a little more. And it's something I think in the last 50 to 100 years of Western life we've kind of minimized. So it's a bit of a rebound recognizing that. And you can't go wrong when we talk about things that, are vulnerabilities and hopes and dreams people have, and it just enters that space. So for me, I think one of the values has always been just, these can be really learning experiences. They teach us something about ourselves, but they also teach us something about, as Harriet indicated, working together on these projects too, the role of caregivers, the role of family. So they're very inclusive experiences as well, despite the fact they're really, may occur within one person. They're of great interest to those around them as well.
Yeah, both beautiful answers. Thank you so much for that. And yeah, thank you for joining me. It was a pleasure speaking with you both. And before I let you guys go, I just want to ask where our listeners can sort of stay up to date on your work. I mean, I hope to have you back on in 5 years or so to talk about the results of CAN-PACT and the progress there. But in the meantime, where can people find you?
Well, we're building a website, right? But it's not quite built yet. I think Linda in University of Calgary and her team there are starting to develop a sort of a website which will sort of host a lot of information and sort of growing, the growing information that we collect, and which we'll promote on that website. But I'm not quite sure where we're at with that website yet. Do you know, Ron?
Coming along.
Yeah.
We might have a logo soon too.
That's nice. Right. We're voting on a logo. The logo.
Hopefully fantastic. A butterfly, but we.
Oh yes. Ron loves the butterfly on a mushroom, of course. But what we'll do is we'll let you know once that's up and running. In the meanwhile, you can always. Certainly anything to do with future trial development will probably be can be found at CCTG. So at the Canadian Cancer Trials Group, we have on our public-facing page, we'll be promoting the trial once it's up and approved and up and running. So details about that will be forthcoming, and probably not in the next, not for another 18 months or so, I would imagine, though.
Okay, sounds good. Well, thank you so much again.
Perfect. Thank you for your interest in this.
Yes, thanks for inviting us.
No worries. Thank you so much for listening to this exciting conversation about psychedelic medicine and cancer care with Dr. Ron Shore and Dr. Harriet Richardson. I'd also like to thank the Center for Psychedelics, Health and Research at Queen's University and the support of our sponsors at the Ontario Brain Institute, the Canadian Biomarker Integration Network in Depression, and Providence Care Hospital. Until next time, be well and integrate wisely.